Good morning, everyone. And this session is going to be a duologue where we'll be discussing the interpretation of thyroid imaging, but we'll be focusing only on ultrasound because that's something which is very, very important when we do any diagnostic test before we go for any FNAC or anything for a thyroid nodule. And an ultrasound is the basic modality which is needed. So, Dr. Asif, you're there, yeah, please. So, this we have already taught about. So, when we come to the first thing, that which thyroid nodule we need to send for ultrasound, the answer is all. So, if you pick up any nodule on a clinical examination, because many times you will see some hypothyroid patients who will be routinely following up with you, and many a times it does happen that you might not have done the palpation of the neck properly. They would have just come for follow-up. And incidentally, one day they'll tell you that I have something in my neck which I'm feeling. Or it is a mandate that every time a patient who is hypothyroid or hyperthyroid or any nodule who is on follow-up, we have to do the neck examination in the OPD. That's the most important thing, because then only we'll know which patient to send. So we'll pick up some thing in the neck, we'll see there is some nodule, we'll feel that there is a nodule, and sometimes we pick up some lymph nodes. So sometimes it might happen that we might not directly pick up the nodule, we might pick up the lymph node, and we may just send the patient for investigation and then we may pick it up. Or there may be sometimes rare case scenarios where the thyroid malignancy has already metastasized and then we pick it up. So these are all the things which happen. So we need to understand the benign nodule, the malignant nodule, and an indeterminate, or where we have a doubt or we are not able to make a correct diagnosis. So whenever we pick up a nodule, we send it for ultrasound. There is no controversy on that. We have to do a basic TSH and T4 at least. If you are suspecting toxicosis, we add a T3 to it. And in case the TSH is subnormal, that means low, then we send the patient for a scan, which is called as a technetium-99 scan. You can also do a radioiodine, but technetium-99 is easily available and most of us do that. So, other important thing is, whenever we send for ultrasound, you have to write that the cervical lymph nodes also have to be seen. Most of the times the radiologist will see it, but we have to also mention that. So to start off the duologue, Dr. Asif, when we send a patient for an ultrasound to you, and you see one nodule, like most of the times it will be benign. Right. So how do you interpret and how do you go ahead further with making a diagnosis?
I think, good morning everyone. Generally when patients come to us, I think ultrasound would be focused with one intention, is whether there is a single nodule or multiple. If there are multiple nodules, we'll try and characterize each one. If it is a single nodule, the job is a little simpler. And obviously, as we discussed earlier on, our job is to see the lateral compartment and central compartment to look for the nodes. So once we see the nodule, we were previously calling them by certain names like isoechoic, hypoechoic, or spongiform, or purely cystic. But all these terms have been revised, and over a period of time, TIRADS is in vogue now. And the reason it is in vogue, because I think to make clinicians understand, with the success of BIRADS, which is tremendous, TIRADS is now being labeled as, a very important tool by which we talk to each other without really talking on phone or something. We just write it so. So I think our job is to include descriptions or descriptors. There are various descriptors which have been previously used in isolation, but like perilesional halo, spongiform pattern, cystic pattern, some other, evaluations, and that could be done by giving the size. And the size is most important, because we have to understand whether it is wider than tall or taller than wide. If it is nodule is taller than wide, we would go ahead and proceed and analyze it for the TIRADS criteria by saying simply amongst all the nodules which is likely to be malignant.
So very important message is that we have to have a staging call as TIRADS, because then only we can make a decision whether to go ahead further with further investigations, and also the size is very important. So these two criteria at least will tell you what exactly to do, and many a times you will palpate a single nodule, but when the ultrasound is done, you will pick up some more, or maybe you might not have been able to palpate because that would have been growing inside, and then you would see that on the ultrasound, which may be a bigger nodule and maybe with a higher TIRADS staging as well. So
that's how a spongiform would really look like.
You can use the pointer.
Yeah, I think in a spongiform, what we generally want you, to highlight is whether it is a purely more spongiform, or whether it is 50% more solid and 30% spongiform. This decides the important yardstick by which I can say if it is a typical spongiform nodule, chances of it being malignant are very, very low. So I think this is what I just included that sponge to make you understand that it really looks like so. And these nodules are generally comparably, little iso to hyperechoic compared to rest of the strap muscles in the vicinity, which is what is the yardstick. So first is the echogenicity, which is generally uniform. Amongst that, if you see nodule, which is if it is hypoechoic or iso to hyperechoic, which is what this nodule looks like.
So, would you, yeah,
Yeah, I
you were
think
talking
there are a
about the
couple of
thyroid.
other nodules. These are the Thyroid's descriptor, but I thought we should just
Yeah,
make
we
it
can-
very simple and make you understand. This is a very nice, benign looking nodule, which is hyperechoic. This part is little bit isoechoic, and this is rest of the remaining thyroid parenchyma, and that is the perilesional halo. If I were to add color here, it would look vascularity all around this. So this nodule, which is very elongated, which is wider than tall, is different compared to a nodule which is seen here, which is a typically hypoechoic because it looks black, and that catches your eye. This black of abnormal thyroid nodule is different than the cystic thyroid blackness, which is a very different fluid-like density. So that distinction is very important for a radiologist to make, that whether it is a cystic complex nodule or whether it is a purely solid hypoechoic nodule. So what gives us understanding is if it is a pure hypoechoic nodule, which is here, it looks more tall than the wide, then this becomes a suspicious nodule. Thyroids does not allow us to use too much of vascularity as an interpretation criteria, but it allows us to use that to say a particular nodule is solid because vascularity is inside. So we use that for that criteria. And there is one more thing is sometimes nodules are in between, then they becomes little bit of complexity, whether it is really wider than tall or taller than wide, then we'll apply other criteria.
Absolutely. So that's very important that we need to understand that. And would you like, we have already discussed a little bit, but you can talk about the calcification because
Yeah.
that's something very important.
I think calcification is something which makes life very easy in the sense, moment you pick up comet tail artifact, which is an artifact, it's not a calcification per se. I hope you can see it here. This is a pure cystic nodule, which is black but not solid because there would not be any vascularity in this, and we see calcific looking specks, but these are not calcification. These are typical crystals which give rise to artifacts. So when there is a short artifact which is seen here, it would be labeled as a comet tail artifact. Moment you see comet tail artifact, it is almost considered 99% benignity because except for the nodules where comet tail artifact can occur in some portion of cystic area within that nodule which has otherwise become malignant. So this is one important comet tail which we should all know. This is a typical abnormal calcification which is a psammoma body, punctate and peripheral. So these are the three P's which you generally look for. So this is those punctate psammoma calcification which makes this nodule highly, highly suspicious. So this is the one of the sign, a hypoechoic nodule with psammoma calcification. So I think this is what radiologists, or even if you were to see on the film and radiologists haven't addressed this, you are likely have right to say that whether we have missed such calcification. And the last is sometimes you get a echogenic ream-like calcification which is coarse, but previously this was labeled as benign, but if there is surrounding mass or if there is any breach in this ream, then again it becomes suspicious. So I think these three patterns of calcifications are important. One is purely benign and other two would show you abnormality.
It can be confused with the inspissated colloid, like sometimes that is one thing which causes confusion, especially sometimes we get confused. So how do we actually differentiate?
So generally in those cases, the radiologists are expected to tilt the patient with the mobile debris gets settled on the other side, and that gives you the clue. Yeah. And generally the comet tail is over towards the superficial portion, while the solid would be little bit deeper.
Yeah, because that's sometimes which we see in the ultrasound and we think, no, this is not looking like a typical calcification.
Right.
And that's something which we get confused. So you were talking about TIRADS. Now that is a very important staging system because many times we will send for an ultrasound and you not get it. So it's always good to write because sometimes most of the radiologists who will be working with you will know it. But sometimes if somebody has seen and they may not be thinking that you are asking for it, they may not write it. So you always want that. So there are different types of tirades. So would you like to comment on different types of
Yeah, I
tirades which we
think
use in
the
our
ACR,
practice?
the American College of Radiology, after the success of BIRATS, they are trying to implement it in various other formats. So one of them very important is the thyroid cancer being so common. So TRATS has been used for one simple important thing is to know which nodule exactly should be FNA'd. I think that is one of the major goal of TRATS is to avoid unnecessary FNACs and at the same time not to miss a nodule which really looks suspicious. If a nodule is small, less than 5 millimeter, it looks suspicious, then there are still guidelines to say whether one should do FNA or no in that case. If it really looks abnormal, but still it is smaller than size, because we go by the assumption that all small cancers would not be really clinically significant. But moment a radiologist says a particular nodule is suspicious, then TRATs come into play, and then by and large, even in my practice, even if it is 6 millimeter, which allows me to wait and watch, sometimes clinicians say you do the FNA because of being suspicious, and the patients would not accept it. But coming to one simple few points which are based on composition, I would not be really wanting you to, teach you this, because this is very easily available and there are TIRADS calculator available online. So moment you see a nodule and we try to put one point and we get the answer immediately, and as well as the recommendation. So we are going to get the answer and recommendation by checking the composition, where you will choose one, that is either cystic, spongiform as I showed you, a mixed solid cystic, or completely solid. That's important. Whether after the composition we will go for the echogenicity, whether it is purely cystic or in between, or purely hypoechoic and very hypoechoic. So very hypoechoic is again important thing, which is solid. So we'll just use color to say whether it is cystic or solid, and then whether it is hypoechoic. Then wider than tall and taller than wide is very, very important criteria, because malignancies are expected to grow along the wrong plane. In the benign lesions are expected to move along the parallel planes, but these will go across the planes, and that's why this comes in picture. Margins, I think we can easily understand that smooth, lobulated, or if it is breach of capsule and is gone out. So simply, I think every point will have additional score. So as you see here, every additional serious or suspicious point will get higher score, and then the score will go up. If we combine all this and the echogenic foci which we discussed few minutes ago, then we will be adding all this and call it TIRADS 1, benign, which is 0, 2, not suspicious, no FNA is required, 3, suspicious, FNA is required if it is more than 2.5 centimeter, follow after 1.5 centimeter, 4 to 6, moderately suspicious, again the FNAC criteria comes down by a centimeter on both criterias, and highly suspicious, this, again the FNA or follow depends on the size. So I think this is how general consensus is, and that is how we follow.
Yeah, absolutely. And also, if you all see that we have the ATA TIRADS also. So if you see here, we have a little bit higher threshold for FNA. So why this was developed? Because they don't want us to do unnecessary FNACs also, and not exactly to miss also. So we'll be discussing the benefits of ACR TIRADS versus the ATA, and how the two are a little bit different. But we know that if you see the threshold for doing the FNAC, it's a bit higher. You can see for TIRADS 3 is FNA is more than 2.5, and for TIRADS 4 also FNA is actually to be done when it is more than 1.5. So that's the little bit of a difference, but it actually helps us to avoid unnecessary procedures as well. So this I think
we can skip that. Yeah.
And this we can skip.
Yeah. We'll go ahead.
So
yeah.
we'll go to with this,
Yeah.
and you can just tell us.
So I think this is just a simple exercise by even those who do not practice ultrasound and don't see it
Anybody in the
regularly.
audience would like to
They would
comment on
just
this?
simply take,
Yeah.
which would be abnormal here.
Anybody can tell which is abnormal, the right one or the left one? Just, you can take a wild guess. Take a wild guess, it's okay. It's okay, we are not all radiologists, sir is a radiologist. But we can take a wild guess. Which is abnormal? Which one is more abnormal?
So I think now that you got it, so I don't have to be here, anymore. Then simply that's the crux of the whole matter, that once you realize by eyeballing only that a particular nodule looks suspicious, you would probably think that why a radiologist would ask for a FNC in a particular nodule, and sometimes We would think reverse, that why endocrinologist is asking for a nodule which otherwise looks benign, because they want to assure a patient which is little bit looking on the higher side, but a big nodule, first time diagnosis, then we add FNAC. So there could be some, changes in this. But as we discuss in this case, right is more hypoechoic, left is more isoechoic. There's a smooth margin, and there are tiny cystic spaces, but there are tiny calcific fossa here, and there's significant abnormal vascularity, and here there is a perilesional vascularity. So I think simply the answer is there. So the right side was medullary carcinoma, and the left was adenomatoid goiter with features of thyroid. We had done the FNAC from both.
So yeah, a little bit about the TIRADS if you want to
I
add.
think TIRADS has been evolving in over a period of time, and QUAC has made European TIRADS. So TIRADS is what we use. There is French TIRADS, there is a Korean TIRADS. These are the two additional things which we use. In Korean TIRADS, the only additional point is they give a significant importance for the lymph nodal status. If the lymph nodes are abnormal, the TIRADS scores really goes for a toss, and then you come back to your thyroid.
That's why sometimes some people say that Korean TIRADS is better with regards to
Yeah.
lymph nodes, and they tend to follow that as well because the lymph node special importance is given, and sometimes that becomes a very important criteria.
Even the FNA criteria have been revised, so it is little bit sensitivity, specificity.
So
And
if we all have the ATA guidelines, it is available online and you all can go and read it.
Yeah.
We have the guidelines for the thyroid cancers, for the nodules, and when to evaluate. That is all available. Basically,
these are,
yeah.
sorry, I'm just
Yeah, please.
interrupting.
Yeah,
These are little coarser guidelines, so the
Yes.
surgeons use it more,
Yeah.
They want something very simple. They don't want to complicate it, so they tend to use this more.
Absolutely, absolutely. So this we have already discussed.
Yes, I think so.
We can move ahead.
Yeah.
So this is the thyroid ATA thyroid nodule guidelines. It's like as we were showing in the previous ACR TIRADS and the ATA, if you see, they almost have a similar type,
Right.
but the threshold for doing a FNA is little bit lower here as compared to the ACR TIRADS. But in our setup, sometimes it is a dicey situation because even if as an endocrinologist, when a patient comes to me, and even if sometimes it's a TIRADS 3 and it's not crossing the mark of 1.5 centimeter, I may still think about doing a FNAC if I think this patient is not going to come back to me for another 2 years. And a patient who is going to follow up with me every 3 to 6 months, I know I'm not justified in doing a FNAC at that point of time. I need to wait because sometimes the radiologist will say it's not needed, and as per the guidelines we are right also. But it also depends on the patient scenario. And many a times it happens that they will say that we have just seen the nodule around a week back. It might have been existing before, but they would have told a short history, and they will, or some will say it's increasing for the past 1 month. So these are all the features which help you to understand, no, this is a patient, I might have a lower threshold. Practically, though, as per the TIRADS, it may not be fitting exactly into that level of, or the size of that nodule. Or sometimes if you have a family history of thyroid cancer in that patient, or a neck radiation history, these are all the important markers which makes you think that you might be having little bit of a lower threshold, and that's what exactly the guidelines say. Do you agree,
Right.
sir?
Yeah, I think the one additional point in ATA, generally it includes the nodes, so that makes it a little more specific than by which radiologists or clinicians would go back to their scenarios in that particular case. And here is the example of something which is tall, and so basically it summarizes all the things. As you go from down topwards, it is TIRADS score would go up, and I think this is just a pictorial picture for someone to look at and try and mix and match. So that is how it would goes.
Absolutely. So it has to be both clinical and the radiological. It's not just one. So we may have one set of things from the patient side, and they may see something else, as sir is telling, that they may see that some patient, we may write that it looks like benign, but they may find it to be malignant. Or we might have picked up one nodule and they pick up the other nodule which is malignant,
Right.
which we might not have palpated. So these are all the things which adds to the thing, and then we take a decision on the patient's thing. So this you would like to just little bit.
Yeah,
add
I
on
think
this?
just additional thing, compared to ACR TIRADS, the ATA guidelines, the TIRADS will allow you to do FNAC exactly similarly, but I think the size here is a little more, so it gives more flexibility, but TIRADS tends to cover most of the features of a particular nodule, while ATA tries to generalize about it. So I think ATA is more of visual, TIRADS is more of mathematical. So I think that's why TIRADS slightly does better. So I think I think we'll,
It's fine.
yeah,
We can skip this because it's like
Yeah.
sometimes some people find it easier. That's the only thing.
Yeah.
But sometimes the mild hypoechoic and smooth like these are low suspicion, but it does not exactly classify. So sometimes those places
Right.
we do have a confusion at that point of time.
This is little
Yeah.
important because there are some challenges in reporting. Say, for example, we also know multinodular thyroid is MNG was considered as a benign term, but it is not a really benign term. So we tend to want radiologists as well as clinicians to use term multinodular thyroid rather than multinodular goiter, because goiter tends to make it look benign. So that is one thing. So there are many nodules. So what radiologists should do, they catalog a maximum of 4 nodules which are ranked by their points. Then second is multiple nodules of same T-RADS category or multiple row risk nodule. Then we make the nodule which is the largest index and characterize the largest. That is the first thing. Then multiple high risk nodule, we recommend biopsy for up to 2 nodules only, not all of them. TR4 nodules which are less than 1 centimeter, radiologist discretion to not require follow-up, or thyroid nodule discovered at some other investigation like carotid ultrasound, then we will recommend a new ultrasound again. And there is inconsistent language, we will be using synoptic reporting, which is online easily available, and we tend to nowadays give it one printout of that thyroid score which comes from online. So I think this is how we look at some of the challenging factors
Yeah,
here.
so ACR TIRADS is clear that if we have more than 2 nodules, then we have to see the highest scoring and go for FNAC of those 2. So that is how we decide. So little bit more about the imaging.
Yeah, I
So,
think this is one interesting video. I think there are a lot of nodules you can see in this. Amongst this, our job is to pick up one which is abnormal, and obviously there is one only which is abnormal. So we'll apply all those criteria and tend to see which is the abnormal one, and we would probably be able to pick up. I think so. I'm just not trying to show all those things, but we'll pick up the wrong color or something which is available here. So we'll be probably doing FNEC from one of them. That is the reason I think this video just run, and we will be able to do FNEC from there. So I think, yeah, next is again similar thing.
yeah.
In this scenario, these look almost innocuous nodules, but because this patient had an abnormal nodule which was mistaken as lymphangioma, the nodules can be so cystic that they are almost mistaken as not related to thyroid, but the aspirate showed that it is from thyroid. Then you go back to the smallest nodule which is less than 5 millimeter or 6 millimeter, then you still want to do FNEC because you need a tissue diagnosis. So this is the importance of overruling the size criteria and coming back here.
Yeah, absolutely.
So I think we'll skip this also. Yes.
Yeah. So this is what is from the ATA guidelines. We all follow that. Like if you have a high suspicion pattern or an intermediate, it's better if it's more than 1 centimeter, we go ahead with the FNA. With a low suspicion, as in the ATA it is mentioned, it's more than 1.5. Very low suspicion, then we wait till 2. So we know that we do that. This is what the guidelines say. But as I told you, practically sometimes we may be a little bit 0.5 less with the sizing. Few of the patients where you are worried about follow-up or it is a recent history. And sometimes you will see that patients come and say that it is recently grown this much. But what I do is I tell them to show the old pictures, because sometimes the close-up pictures you will see something in the neck. And you will see that 10 years before also the same thing was existing. And they might have noticed today, or some doctor might have picked it up. So that gives you a clue that you don't end up doing unnecessary FNACs. Not that we don't have to do, but we should not end up doing unnecessary tests also. And it's a benign pattern, then you can just follow up. Because many a times they may have these nodules existing for years together and the size hasn't changed much. So you can just follow up these patients. And we know that we have to have a cytology after that, and that has to be done by a specialized pathologist. Not that anybody can make the slide, because you have to talk to the pathologist what you are thinking. Because sometimes they may just give, not possible to give any opinion. Then we can't just leave it at that. Or sometimes 15% of the times FNAC may miss a cancer. So it is always good, if you have a strong suspicion with a TIRADS 4 or 5, you should follow up more frequently if your suspicion is higher, rather than just leaving it that because my FNAC did not show up the cancer and I can just leave it like that. So that's another thing we have to be worried about, because sometimes the FNACs may miss a cancer because they might have taken from the center, they might not have taken from the tissue. It's always good to do a USG guided. So what is your opinion on that?
Yeah, I think so. It makes simple sense, because there is a very good chance that amongst the nodules you are likely to pick up. This was one nodule which looks quite benign, but we had to do FNAC. Then we would choose certain area from us. Amongst that nodule was the most hypoechoic area which looks solid. And believe me, this was papillary cancer. So it becomes important that radiologist uses his discretion while doing the FNEC, where to do it from, and simple tools like little bit hardness or something can help them. So this was one important, message here. And secondly, pathologist gives non-diagnostic aspirate, which makes patient feel very nervous that doctor didn't do job well, both of them, they say non-diagnostic means you haven't done job well. So you have to simply tell them that the nodule belongs to that category. If it is non-diagnostic and thyroids 1 also, we would allow it to pass it as normal, and there would not be any further imaging or further FNAC required. But something which is this Bethesda 3 category, there we would probably sometimes do repeat FNAC to make little bit more concrete. FNAC is also done by 2 methods. One is with aspirate method and one is with non-aspirate method, because thyroid being a very vascular structure, sometimes the bloody smears come. So we would do both, and if that solves the problem, I think we are on the right track. And this is what we tend to do for those indeterminate nodules on the Bethesda category.
And some of the times when we don't get a typical picture, it's not just that they have not been able to get the tissue. We don't keep on poking the needles. We wait for 3 months, because then we do a repeat, because otherwise you will cause unnecessary injuries and you may not be able to make the correct diagnosis as well, because there will be inflammatory smears there. So what we do is we wait for 3 months, we tell them to follow up, and then we decide, because 3 months is a good time to wait in case you have a very high suspicion index.
A complex nodule, just I'll add one point, we aspirate first cystic portion and do the FNAC from the solid portion separately.
And the message is it's better to go for ultrasound guided. In my practice, I normally prefer that, because especially what will happen, as we saw, that they may pick up just from the fluid and you may not actually get the tissue and you may not get the correct picture. So it's always good and a wise decision to do, and it avoids unnecessary pricks also for the patient.
Right.
So this.
So there is some difference between the the various guidelines, but amongst all the guidelines which are available, the ACR thyroids tends to have a better scoring system, by which identification of cytological high risk nodule is better compared to the ATA guidelines, which keeps a lot of nodule unclassified. So that's the only message, that we should rather use thyroids for this reason, because the it zeroes down better amongst all the nodules. And there is always a contradictory papers come in the endocrine journals, even the radiology journals, that some of them believe that ACR thyroids and ATA guidelines scores are helpful for the management of thyroid nodules with indeterminate cytology. That is generally the Bethesda 3 category. And while someone will say it is not really helpful, but I think this would be solved by using it correctly in a typical clinical scenario where we speak to endocrinologists as well as pathologists and then take a call. So this is the important thing.
So that we have already discussed, that FNA thresholds are a little bit higher in the ACR terads as compared to the ATA. So we see that it's like 0.5 centimeter higher. So it tends to avoid unnecessary FNACs, and that's, I think, a good thing. But practically, as I told you, we have to see the patient scenario, the report, and then take a decision. So when we send a patient for ultrasound, and
right,
sometimes they don't write the terads, and sometimes we don't get a correct picture because many people may not be doing it correctly. So do you have a check sheet sort of a thing?
Yeah, we generally have, this is available online, and generally we tend to derive it one for your own institute, and most of the institutes have some tables, some have charts, some have figures. But what is important here is to actually put the score there, give the location, know which is the index nodule, which are the other remaining 3 nodules, that means 1 plus 4, and the compartment, lateral and central compartment, where there are nodes. So just simply we tend to draw some lines by some particular color saying that this is abnormal, rest looks normal, and at the end of it, there has to be a recommendation, which is what is required, which is a recommendation. It's not necessary, it's a completely, rule of that you have to use, but the recommendation will also sort out one more problem, is to know what to do in a particular thyroid's 3 nodule over a period of time, 1 year, 3 year, 5 year. So these guidelines come from this recommendation, because it is again given in the format which we write here. So this is generally very nice for patient also to understand, and a clinician also to understand.
So it's very important that we need to be very sure that the TERAS has been done correctly for the patient. So this you
About the autonomous nodules, I think generally we don't deal with it because we don't come to us. It is once you see it is abnormal with TSH being low, I think you
then
people.
we mostly send for the technician scan and we see if they need surgery or radioiodine, and that those patients are managed for a short time on antithyroid, but then most of the times they will need one final management, mostly as a radioiodine ablation, or we will send them sometimes for ultrasound just to see that there is nothing else existing.
Right.
And we also do a TC99 to see one autonomous and if there is any cold nodule existing, because the chances of malignancy may be higher.
Right.
And sometimes we may be having a big autonomous nodule, but we may be having a small cold nodule sitting there, which may be needed to be investigated before we proceed ahead with a radioiodine ablation for that patient. So that's why it is very important.
I think one point here is generally the autonomous nodules which are treated or otherwise, they tend to not follow thyroids correctly and they generally go a little higher score, though the FNAC would come negative. So even radiologists should remember this point.
So that is why for autonomous nodule, we are not much going for the USGs. Our purpose of doing is sometimes we do see a cold nodule in the TC99 scan, and then we have to investigate that before we plan for a radioiodine ablation for that patient. So we would be also sending the patients for those reasons. Now, very, very important thing which we see most of the times in an ultrasound report, thyroiditis. And patient will come running to us that I have got a diagnosis of thyroiditis. Now do something. So what exactly how do you comment on that?
So I think it's a clinical diagnosis. It's not a radiologically required, but it will be documented in some cases or it will be an incidental finding. We tend to see a lot of cancers, even PTC or lymphomas, they have background thyroiditis and we tend to pick it up. Generally, we see a very heterogeneous thyroid, and we would take vascularity for one reason is thyroiditis at some point may have similar features to Graves, where a vascularity would be very high vis-a-vis this. So this is one important point, the size, the overall background carpet, how it looks, and the vascularity. I think these are the 3 points. We do not classify them only on radiology that it is a particular type of thyroiditis. So this is just one picture for you to understand that a normal thyroid tends to retain so much iodine. So this is on plain scan, looks so bright, but moment there is thyroiditis, it tends to lose that iodine and it will look black. So this is only on the plain scan picture. And similarly, ultrasound also corresponds similarly, that a thyroid looks something very simple and normal compared to the strap muscle. Here the strap muscles and thyroid look similar, and there is a lot of fibrotic background by which this looks like a cirrhotic liver, something like that. So thyroid starts looking like that. So that's the general descriptor.
And anytime if you have a TSH low and a T4 higher or normal, high normal, and a T3 normal or high normal, then it is the thing that you have to go for a TC99 scan. You have to differentiate, because many of them may be thyroiditis, where they'll show an absolutely no intake or no uptake or little bit of the uptake or very less uptake, and then you will have Graves where you'll see a very high uptake, and then you will have a picture where you may also see in the recovery phase of thyroiditis, sometimes you may see an increased uptake when they are recovering. So that all also depends on your clinical decision. And also sometimes you will find toxic nodules or you will find toxic MNG. So these are the things which you will pick up on the TC90. And that's why in the beginning we told that anybody having a TSH subnormal, where we are thinking in terms of thyrotoxicosis, we have to go for a TC99 scan also. But also whenever you do a TC99 for Graves, many times you will pick up cold nodules. So that is also one place where you will definitely send for an ultrasound, because you now want to investigate that cold nodule also, because that is something which might be malignant, so you might be worrying about it. So this, would you just
These
like
are
to,
just typical appearances, that Swiss cheese or the leopard skin is what we generally call, or the giraffe skin, whatever it is, hide. So this is how it generally looks, and that's a very classical thing. One of the reason why I would little bit take few seconds here is, once we diagnose a thyroiditis over a period of time, there is still a small risk, less than 5%, there could be a PTC. So some of these patients do require follow-up to rule out PTC or lymphoma which is developing against the background of thyroiditis. So it is not the full stop. People should be made aware that whether they feel any change, they should be slightly nodularity wise or any new nodule, they should go back to imaging through their clinician.
Because we recently had a patient who was Hashimoto's thyroiditis and she was following with us for a long time, and then she suddenly came with enlargement of the thyroid and it was going on enlarging and she turned out to be lymphoma actually,
Right.
which is very rare, but she turned out to be lymphoma. So we all have to be cautious about it. We should know, not that we should think for every patient, but these are few things which we should not miss. And many a times you will want to follow up because we know that even Graves' disease patients may have a higher incidence of papillary CA, especially the tall columnar variant is more common. So we might, as I told you, if you pick up a cold nodule, you have to investigate. And before you send the patient for radioiodine, you have to do an ultrasound because you have to see if there is any nodule which you might have missed, which is a suspicious nodule. Because then you might like to investigate that before you send your patient for a radioiodine. So those are the places.
Yeah.
And
That's a
focal thyroiditis, would you like
focal
to?
thyroiditis just always causes confusion as a tumor, but simply when radiologists think it is a focal thyroiditis, even though it looks like neoplastic, we just simply tend to follow them up by doing some antithyroid antibodies and the other investigations, the ESR and CBC. That helps us. We don't really rely on that as a radiologist, but we would take that complete picture, and as you can see in this picture, that same nodule has become vanished exactly in 2 months time, and it is completely, otherwise at certain point someone would do FNAC, which can be avoided again.
Especially in subacute thyroiditis, they'll go for an ultrasound and small nodular things will be seen. So we should not need to go for FNAC at that point of time. Follow up the patient, and most of the time these nodules will disappear on follow-up. So
Right.
small nodule, we'll see a nodular sort of a thyroid. A little bit about the Graves, because we know we do the TC99 scan. We're just finishing off, it's the last one. So we do a TC99, but anything special which we see on the ultrasound?
Yeah, I think it's a vascularity, which is the inferno, which is clinical. In this case, I think the patient came actually for the lymph node, but we found out she already looked thyrotoxicosis. And this is one picture which you would make, if were to work. There's a lot of vascularity. The video didn't work here, though I think it's on. And there is the thyroid inferno, which draws your attention. And we use it over a period of time, whether the thyroiditis is changing its pattern from the high velocity, which ranges above 60 to 70 centimeter, which is a velocity taken in the inferior thyroid artery for consistency. And then over a period of time on treatment, if they're doing well, the velocities drop down. So this is a one important point.
Yeah, so that's an interesting thing. So
And some
can
differences, I
yeah,
think we can
let's
skip
keep
this.
it off,
Okay, yeah.
So just the take-home message is that whenever you find any nodule, always do a palpation of the thyroid. It's always good to do because you may pick up many things. You may pick up even papillary CA, which you might be missing. So it's always good to check for the thyroid and see for any nodules. Check the lymph nodes also. Don't forget the lymph nodes. TIRADS is a very nice way which helps us to understand which patient we should go for further FNAC and which patient we shouldn't. Follow-up is very important because many a times you will not get the answer. So answer is follow up the patient. You may decide whether 3 months, 6 months, you have to follow up and always give a guidance to the patient that if they find increase in the size, if they find compressive symptoms, voice change, breathing difficulty, any swallowing difficulty, they should come and report. Maybe it might not be related, but you should tell them to report. And if they find any other new swelling coming up in the neck, which might be a lymph node, so tell them to report to you. So you may not miss, because sometimes even with the imaging and with the FNAC, you may not be able to make the final diagnosis to decide on the further treatment. And definitely if any compressive symptoms are there, and no matter if you're finding the TIRADS to be lesser or you're finding that patient already has voice change and other problems, that increase in the size is happening, it might be a wise decision to go for further FNACs and see, because those are the cases where your clinical judgment may play a better role. So sir, you would like to give your final comments, please?
I think everything has been said and done with. Just few things. One is the criteria about the cold nodule. Sometimes the cold nodule on isotope scan may be actually a cystic nodule. So I think that is one important point. And secondly, the PET scan hot nodules, about 50% are abnormal, 50% may be still normal. So that is one thing, because it would come to you in future. And third thing is, I think to decide whether a FNAC is required or no depends on a lot of other factors. So as a endocrinologist, maybe simple thing for you is to ask radiologists to use TIRADS, because many radiologists do not use these TIRADS, to make your life little easy on paper, by which you get a correct recommendations for follow-up as well as FNAC. So I think that's the most important. Thank you so much.